Here's something your doctor might not tell you, and it's not because they're hiding anything. It's because the medical system is built around doing more. More tests, more screenings, more scans. And for most of your life, that makes sense. Catching things early saves lives. But here's what the latest research is revealing. After 60, some of those routine screenings that once made perfect sense can actually do more harm than good. Not because the tests are bad, but because of your age, your life expectancy, the anxiety they cause, and most importantly, the cascade of follow-up procedures that an ambiguous result can trigger. Today, we're looking at 5 health checkups and screenings that major medical organizations are now questioning for people over 60, and in some cases, actively recommending against. This isn't about skipping your annual physical. This isn't about ignoring your health. This is about being an informed patient, knowing when a test genuinely helps you and when it might just put you through unnecessary stress, cost, and risk. Let's get into it. The over-testing problem. First, a little context, because this might feel counterintuitive. We live in a culture that equates more medical testing with better health, and for decades that was broadly true. Mammograms, colonoscopies, PSA tests, these screenings genuinely saved millions of lives. But medicine has evolved, and with decades of data, researchers have started asking a harder question. For whom does this screening actually improve outcomes? There's a concept called lead time bias, the idea that detecting a disease earlier doesn't always mean you live longer. It sometimes just means you know about it longer. Meanwhile, the diagnosis itself and everything it triggers affects your quality of life. There's also the problem of overdiagnosis, detecting abnormalities that would never have caused symptoms or shortened your life, but that, once found, feel like they demand action. That action, biopsies, surgeries, radiation, carries its own serious risks. The U.S. Preventive Services Task Force, the American Geriatric Society, and other major bodies have been quietly, and in some cases loudly, updating their guidelines. And for people over 60, the picture looks very different than it did 20 years ago. Now, let's look at the 5. Number 1, the PSA test for prostate cancer. If you're a man over 60, there's a good chance your doctor has ordered a PSA, prostate-specific antigen, blood test at some point. For decades, it was considered routine, standard, obviously good. Here's the problem. The PSA test measures a protein produced by the prostate gland. Elevated levels can indicate prostate cancer, but they can also be elevated due to a benign enlarged prostate, a urinary infection, recent physical activity, or simply normal aging. The test has an enormous false positive rate. And here's what happens when that result comes back elevated. Anxiety spikes. Follow-up biopsies are ordered. Biopsies carry real risks. Infection, bleeding, sepsis in rare cases. And if cancer is detected, the question becomes, is this a slow-growing cancer that will never threaten your life, or an aggressive one that will? Studies, including the landmark European randomized study of screening for prostate cancer, found that for every prostate cancer death prevented by PSA screening, roughly 30 to 40 men were overdiagnosed and unnecessarily treated. Treatment for prostate cancer, surgery or radiation, can cause incontinence and erectile dysfunction. For a slow-growing cancer that would never have caused symptoms in a man's remaining lifetime, that is a devastating trade-off. The U.S. Preventive Services Task Force gives PSA screening a C recommendation for men 55 to 69, meaning the benefit is small. For men 70 and older, it's a D recommendation, meaning they actively recommend against routine screening as harms outweigh benefits. This doesn't mean ignoring prostate health. It means having an honest conversation with your doctor about your personal risk, family history, and what you would actually do with the information before getting the test. Number 2, annual mammograms after age 75. This one tends to generate strong reactions, and understandably so. Mammograms have saved countless lives. For women in their 40s and 50s, the calculus is relatively clear. But after 75, breast cancer in older women often grows more slowly. Many older women have other serious health conditions, and the harms of mammography, false positives, unnecessary biopsies, overdiagnosis of tumors that would never have caused problems, don't disappear just because a woman is older. They arguably become more significant. A major concern is overdiagnosis. Studies suggest that mammography programs detect a significant number of cancers that would never have become life-threatening. In a younger woman with decades ahead of her, even small treatment benefits outweigh this concern. In a woman of 78 with other health considerations, the calculus is entirely different. There's also the emotional and physical toll of a false positive, a suspicious mammogram that leads to additional imaging, biopsies, waiting, anxiety, only to come back as nothing. For older patients, that process is genuinely taxing. The U.S. Preventive Services Task Force states that evidence is insufficient to assess the benefits and harms of mammography screening in women 75 and older. The American Geriatric Society suggests that for women with a life expectancy of less than 10 years, the harms likely outweigh the benefits. This is absolutely a personal decision, made in conversation with your doctor, accounting for your health status, your values, and your family history. But the automatic assumption that more screening equals better care deserves to be questioned. Number 3. Colonoscopy after age 75. Colonoscopy is one of medicine's genuine triumphs. Catching colon polyps before they become cancer has prevented an enormous number of colon cancer deaths. So why is this on the list? Colonoscopy is not a risk-free procedure. Particularly in older adults, the prep itself, the intensive bowel preparation, causes dehydration and electrolyte imbalances that can be dangerous. The procedure carries a small but real risk of bowel perforation, and sedation risks increase with age. Meanwhile, colorectal cancer is typically slow-growing. The benefit of catching it early is most significant when you have 10 or more years for that benefit to materialize. The U.S. Preventive Services Task Force recommends that colorectal cancer screening stop at age 75. For adults 76 to 85, it says the decision should be individualized. For adults over 85, it recommends against screening. The harms outweigh the benefits. This applies to routine screening colonoscopies. If you have symptoms, blood in stool, unexplained weight loss, bowel habit changes, that is a different situation requiring prompt attention regardless of age. If you're in your late 70s or 80s, ask your doctor directly. Given my age and health, does the benefit of this colonoscopy outweigh the risk for me specifically? Number 4, and this one surprises a lot of people. Routine full-body CT or MRI scans. You've probably seen advertisements for these. Walk-in scanning centers that offer peace of mind. A head-to-toe scan to catch anything lurking that you don't know about. Sounds sensible, right? Look everywhere. Find everything early. Here's the problem. Your body at any age, and especially over 60, contains a remarkable number of incidentallomas. That's the actual medical term. An incidentalloma is an abnormality found incidentally during a scan done for another reason, that is of uncertain clinical significance. Full-body scans virtually guarantee that something will be found. A small shadow on a lung, an unusual-looking nodule on an adrenal gland, a spot on the liver. The vast majority of these findings are benign and will never cause problems, but once they're found, they cannot be unfound. You now have an abnormality. Your doctor is obligated to follow up. So begins a cascade. More scans, biopsies, specialist consultations, worry, sleepless nights, all for something that would have never affected your health. And CT scans aren't benign themselves. They deliver a meaningful dose of radiation. Multiple CT scans over time carry a non-trivial, cumulative radiation risk. No major medical organization, not the American College of Radiology, not the USPSTF, not the American Cancer Society, recommends whole-body CT or MRI screening for asymptomatic people at average risk. The ACR explicitly advises against it. A full-body scan is not a substitute for a relationship with a physician who knows your history. Targeted imaging for specific symptoms is entirely appropriate, but scanning everything just to check creates more problems than it solves. Number 5, the routine annual ECG or electrocardiogram for asymptomatic older adults. Many people over 60 receive a routine ECG as part of their annual checkup, particularly before procedures. And for people with heart symptoms, chest pain, palpitations, breathlessness, an ECG is absolutely the right call. But for people with no cardiac symptoms and no known heart disease, the ECG, while painless and cheap, generates significant numbers of incidental findings. Minor variations in the tracing that look unusual but are clinically irrelevant, except that once documented, they trigger further testing. Stress tests, echocardiograms, specialist referrals. There's also evidence that some findings on routine ECGs, like left bundle branch block, can falsely indicate heart disease when combined with other tests, leading to inappropriate interventions. The U.S. Preventive Services Task Force recommends against routine ECG screening for low-risk adults, those with no symptoms and no cardiovascular risk factors. The evidence shows no benefit in reducing heart attacks or cardiovascular death, while harms from downstream testing are real. If your doctor orders an ECG because you have high blood pressure, diabetes, or significant family history, that's completely appropriate. But the automatic annual ECG for a healthy, asymptomatic person? The evidence doesn't support it. Now, before you walk away thinking you should cancel every medical appointment, let's be crystal clear about what still matters enormously after 60. Annual blood pressure checks? Absolutely. Hypertension is a silent killer and easy to treat. Cholesterol and blood sugar monitoring? Yes, especially if you have risk factors. Annual flu vaccine and keeping up with boosters? 100% yes. Infectious disease is a serious risk as we age. Bone density scans for women postmenopause? Yes, osteoporosis screening has strong evidence of benefit. Skin checks if you have a history of sun exposure? Worth discussing with your doctor. Vision and hearing checks? Critically important. These affect falls, cognitive health, and quality of life. Cognitive assessments and depression screening? Absolutely. Mental health deserves as much attention as physical health. The goal is not to disengage from medicine. The goal is to engage smartly. To ask your doctor, what is the evidence that this test will improve my health? And what would we do with the result? And is that something I want? That is what good, modern, patient-centered medicine looks like. Here's the bottom line. The best thing you can do for your health after 60 is to have a doctor who knows you, not just your test results, but your values, your goals, your family history, and what quality of life means to you. A doctor who treats you as a person, not a checklist. Medicine is not one size fits all, and the older we get, the more individual that calculation becomes. What's right for your neighbor may not be right for you. The question is never, is this test available? It's, does this test help me? Be curious, be engaged, and be willing to ask the uncomfortable question, Doctor, do I actually need this? If this video helped you think differently about your healthcare, please share it with someone you love who might need to hear it. Subscribe for more content on health, longevity, and living well in the second half of life.